Hello and welcome to today's Center for Healthcare Strategies 25th anniversary panel discussion on maximizing Medicaid's potential to close the disparities gap and improve health equity. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session after today's panel discussion. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Allison Hamlin, President and CEO at the Center for Healthcare Strategies.
Thank you, Travis, and welcome everyone. Thank you so much for joining today's panel discussion. I'm Allison Hamlin, President and CEO of the Center for Healthcare Strategies, and I'm so honored to host today's event on behalf of all of my colleagues at CHCS. To mark our 25th anniversary, we wanted to do what we do best as an organization, and that is to bring together leading minds in the field, representing various stakeholder perspectives to advance our understanding of how to use Medicaid's various policy levers as effectively as possible to address the most pressing issues of our time. Our 25th year has coincided with many overwhelming challenges, as you all know. But a connecting thread across all of them has been a deep reckoning with racial inequities. And so, in this week that we honor the legacy of Dr. Martin Luther King Jr., we could think of no more fitting way to mark our organizational milestone than by convening a conversation with some of our outstanding partners around how to best leverage Medicaid to really move the needle on health equity. Next slide, please. Let me start by giving you a quick rundown of today's agenda. I am momentarily going to introduce our esteemed panel and provide some brief context on CHCS and the context for today's discussion. I will then hand over to our moderator, CHCS Board Chair Estelle Richmond, who will share some of her own remarks and then jump us right into the panel. As Travis mentioned, we will reserve the last 20 minutes of our conversation today for audience Q&A, and I will recap the instructions for doing so and participating in that in just a moment. Next slide. And so I have the great privilege of introducing our panel today, which represents a mix of state, federal, and provider perspectives, and to a person, inspiring champions for equity. Our moderator is Estelle Richmond, who has served as CHCS Board Chair since 2017. She is the former Secretary of the Pennsylvania Department of Public Welfare and has served at the federal level at the Department of Housing and Urban Development under the Obama administration, and she has also committed years of service to the city of Philadelphia. Toyin Ajayi is co-founder and Chief Health Officer for City Block Health and formerly served as Chief Medical Officer for Commonwealth Care Alliance in Massachusetts. Maureen Corcoran is Medicaid Director for the state of Ohio and has a long history of state service and advocacy for populations with complex needs. And finally, Marcia Lily Blanton is Associate Research Professor at George Washington University and has formerly served as Chief Quality Officer for Medicaid and CHIP at CMS. Thank you all so much for sharing your time and your insights with us today. Next slide, please. So as Travis mentioned at the outset, you can feel free to use the Q&A button at any time during today's panel to submit a question. My colleagues and I will be going through those, and again, during the last 20 minutes of our time today, we'll be fielding as many of those as we can to our panelists. So please go ahead and share those with us as you see fit. Thank you. Next slide. For those of you who don't know CHCS, we are a nonprofit health policy center whose mission is to support innovations in care delivery and improve the health of low-income Americans. Next slide, please. Since our founding in 1995, Medicaid has been our constant and primary focus. Over 25 years, we have aimed to use our technical assistance, best practice dissemination, and leadership and capacity building skills to benefit the diverse array of subpopulations served through the Medicaid program, ranging across the lifespan from maternal health and EPSDT through long-term services and supports and end-of-life care. Over our many years, CHCS has become a go-to resource center for improving care for children served in multiple systems, including Medicaid and child welfare, for adults with complex health and social needs, and individuals who are duly eligible for Medicaid and Medicare. We have supported states and their partners at critical junctures in their Medicaid evolution, including their efforts to expand coverage under the Affordable Care Act, their efforts to design and implement Medicaid accountable care organizations and related value-based purchasing strategies. And we've also supported Medicaid directors through the Medicaid Leadership Institute, which itself is celebrating its 10th year this year. Next slide, please. In 2020, we, like many of you in the field, have felt an unparalleled call to action around addressing health disparities, particularly those related to race and ethnicity. Across our 3 program priorities, as represented here, we have an array of initiatives that center on equity, supporting states, plans, health systems, and providers in their various efforts to close gaps in quality and access, and to address underlying systemic and institutional barriers to health equity. And in addition to this externally facing work, we are also tackling our own internal practices, policies, and culture, recognizing that we can't ask others to take on this hard work without making the same commitment ourselves. Next slide. And finally, before handing the floor over to Estelle, I just want to underscore that Medicaid and its partners are uniquely situated to address health disparities. As a source of healthcare coverage to more than 75 million people across this country, with overrepresentation of children and adults from Black and Hispanic communities, Medicaid is in a tremendous position to be a driving force toward more equitable outcomes. As the program has evolved and grown more sophisticated in its tools and approaches in recent years, it has developed and refined many of the key levers needed to advance this goal. For example, through targeted use of data and quality measurement, contracting requirements, payment strategies, effective member engagement, and benefit design. And with that, it is my true pleasure to turn the floor over to our moderator, Estelle Richmond.
Thank you, Allison, for that great introduction of CHCS and how we've spent the last 25 years. I'd like to thank all of you for joining us. But before I start with my opening comments, I have a couple of things that I need to thank too. First, I want to acknowledge that CHCS's 25th anniversary and to thank all prior board members and staff who've made this longevity possible. Second, I want a special shout out to Steve Summers, who I here is on today, who is our founder and longtime CEO. Thank you, Steve, for your vision and the durable mission for CHCS. In the best of times, there are many challenges for a Medicaid program, whether it is part of an umbrella department, as it is in Pennsylvania, part of a health department, or a standalone department. Medicaid directors are pushed to do even more with less funding, to find creative ways to generate revenue, and to find even more creative ways to save dollars without hurting patients, healthcare providers, or other partners. It is a complex, often thankless, but critical job. Having been in a position where the Medicaid program reported to me, I know firsthand the value of CHCS and their ability to not only train, but support the Medicaid department with new and fresh and creative activities. It was always a pleasure to be able to reach out to them and get this help we need. I'm sure many other secretaries across the state have had that same feeling. But even more challenges await people who rely on Medicaid for their health care. By definition, they are poor, often at or below the poverty line. They are most often children, moms and dads, and people with co-occurring chronic illnesses such as asthma, diabetes, mental illness, and addictions. They are working at minimal wage, most often without health insurance. It often came to a surprise for those of us who had to interact with the legislators to let them know that many people who are on Medicaid are also working. They seem to think these were people who often did not work because they didn't want to work. We found more often in Pennsylvania that indeed people on Medicaid worked, but they made minimum wage, and most of those jobs did not have any type of health insurance. And yes, many of these individuals had other major life challenges. They had unstable housing, food insecurity, fluctuating eligibility, and work insecurity. They were often first laid off when there was a problem. And yes, this all defined the social determinants of health. We began to realize that healthcare is just not funding hospital stays or doctor's appointments. It's also understanding the impact of your life challenges along with your healthcare. These are individuals that make decisions every day about their healthcare. They decide whether to take time off from work and lose pay or make a preventive health appointment. They make decisions about whether to spend money on copays or food, or money on copays or rent. Every $25 or even less helps determine where funds go. They make decisions on whether to get routine care or postpone it and end up getting urgent care. These are decisions that people on Medicaid live with on a daily basis. During my tenure in the Obama administration, I witnessed partnerships between HUD and HHS as we learned that stable housing supported good health outcomes and that local partnerships supported long-term change. Secretary Sebelius and Secretary Donovan worked together, as we must, to reach a point that healthcare is supported by all aspects of, of our society, not just one. That we, working together, that we can all begin to redefine our healthcare system. We have known for years that our healthcare system is fragile and that the poorest of us are the most vulnerable. We have known for years that health disparities and the impact on people of color. And we have known for years that urban areas are extremely vulnerable for contagious diseases. However, the pandemic, COVID-19, hit us in the face with these realities. We can no longer move slowly to close these disparity gaps. We can no longer wait and have the time to begin to decide what is the right policy. We are now in a mode that these have become urgent. And if we have learned anything from the trauma of 2020, it is racial disparities, health disparities can no longer wait for an all due time. As we welcome a new administration to Washington tomorrow, we have an opportunity to be intentional about our work to close these disparities. We can become intentional about health equity. And indeed, we can now begin to change our path to one of urgency and true healthcare for all. In many ways, those of you on this call have struggled with this reality. We can now come together, work together, and find ways to use the lessons from COVID to improve our healthcare system overall. Our panel today will speak to how Medicaid can be a tool to close these disparities and truly begin to help us heal as a nation from a year of trauma. Let's begin our panel discussion, and I will give our panelists a chance to come online. Great, it is good to see all of you. Toya, last year has been unprecedented in so many ways, with so many challenges for the nation's healthcare safety net. Can we begin on somewhat of an optimistic note? Where do you see glimmers of hope arising? What are you excited about for instituting long-term change to address equity for Medicaid members?
Yes, what a tee up. Thank you so much, Estelle. I really appreciate the entire sort of setup for this panel and your great wisdom and your remarks. I am by nature an optimistic person, but even in these times, I have to dig deep for this one. But I take a minute to reflect. So just for context for folks, very briefly, I'm a physician. I'm a family doc by background and founded City Block almost 4 years ago now with the specific intention of using the opportunity that we have to drive better, more equitable, more sustainable and scalable outcomes for populations who need it the most, in particular folks who receive Medicaid. And it has been tremendous to see that the tailwinds of the work that so many have done, particularly on policy, to enable value-based care, to enable a recognition of the importance of social drivers of health, and the ability to stand up and to scale an integrated model like ours that takes physical health and behavioral health and social health and considers them all as meaningful drivers of health and well-being, that can explicitly take an equity framework to focus and invest resources in communities and drive better outcomes. The fact that I'm here and we, as of last week, we're able to announce yet another partnership in the state of Ohio, really demonstrates that there has been significant movement in the ability for payers and for providers to orient around value and values-based care, specifically for these populations. So I think that's one thing that gives me a lot of optimism. I think as we reflect on what we know to be true now about the population that receives Medicaid benefits that you described so much, how heterogeneous that population is, how so many folks are working, how deserving of a better experience and a better set of outcomes this population is. I think we are changing some of the framing and the narrative around investing in this population, and I think that's a good thing, and that gives me hope and optimism. And then finally, I think, to just reiterate the importance of our recognition as a society of the importance of social needs and social drivers of health. It's now, you don't have to sort of jump up and down and scream and kick as we used to even 10 years ago, explaining that, it's impossible to expect people to get better if they have no food, or they have no place to sleep, or they have no trusted relationships in their lives. We take that as a norm, as a given now, and we take that as given that our obligation as people who are invested in and fighting for health and well-being have to think about all of those drivers. And that too gives me optimism for the way that we think about spending our resources, the shifting the balance away from hospitals and expensive reactive care to really investing in communities. So I'm optimistic. We'll get there.
I would say, Toya, just listening to you makes me optimistic. and for someone who's been around for a long time, to see a young doctor with so much energy and optimism, I think just gives us a reason to begin to look at how great the future is. Let me just quickly reach out and see if Maureen or Marcia have anything they want to add.
I can start because, I'm optimistic as well, because I saw, I've seen a change in we have new leadership at the national level that is truly committed to some of the principles that we stand for, and also committed to helping this nation heal, because we're going to have to do that if we're going to move forward. And so that gives me optimism. But I've also seen mass movements, social movements for change, as we used to call them in the day, whether it's Black Lives Matter or so they're just a number of social movements that are cross-generational, cross-racial, and that gives me optimism, because we need change from the top, but change from the bottom. We need it's the winds that kind of cross each other that can foster change. So I too am optimistic.
Thanks, Marcia. Maureen, as the Medicaid director in the group, in Medicaid programs across the nation, but let me stop. Thank you for all you do. I'm one of those that recognize that the Medicaid director is often the target for everyone. They think you control and it's all your personal money. So as one of those who recognizes where money truly comes from, I thank you for all you do. There is a focus on changing policies that led to racist and unequal outcomes. But for these changes to be effective, institutional and organizational cultures need to change from within, something that may not be a priority focus. How can Medicaid leaders embrace and use this momentum to both drive programmatic and institutional change?
Well, thanks, Estelle, and thank you to my colleagues on the panel. In Ohio, we are predominantly a managed care state. More than 92% of everyone on our program is in a mandatory managed care program. And back beginning in 2019, we began a process of listening, spent quite a bit of time going around the state, listening to individuals served in the program about what we needed to do to change. And we're now in the midst of a reimagining of our Medicaid program, reprocurement of the entire program, and probably most fundamental both to this conversation and to the work we've been doing is our theme is to put the individual first, not the business of managed care. And I would submit to you that there is no quality in care without equity and without having each individual at the center of our focus in a healthcare experience, whatever their background, whatever they come from, whatever their journey in life. You know, as a nurse, I can certainly speak to the importance of just understanding where each person comes from. And to me, that is the fundamental goal that we've set out as we reform our program, but as we also try to really grapple with all the issues and all the ways in which racial and ethnic diversity is harder for those who are trying to access really good quality care. And just one last, sort of comment is, as we go through our discussion today, we can have passion and we can have pilots, but we have to have a plan and a systemic change. The passion isn't good enough. The pilots are not good enough. We have to link arms. And some of the examples, maybe we'll have a chance to share some of the things we've been trying to do to bring all of our managed care partners together with us, all rowing in the same direction, all leaning on exactly the same levers in order to try to address some of the most difficult issues of our healthcare system that we face. So our managed care partners are arm in arm with us. This is an excellent opportunity and a prime time in our country to take advantage of the role that Medicaid plays to lean in further and more on some of these really difficult healthcare challenges.
Thank you. That's terrific. And we will be interested in hearing more examples as we get into the panel. Marcia, one of the things I think we all know is that the federal government plays a major role in both setting policy and regulatory and oversight. How do you see the federal government using this role to be more effective in promoting health equity through Medicaid?
So first, I also want to thank you all for inviting me before I answer that question, because I can't think of a better way to spend an hour than with people who I know are concerned about equity, but also concerned about Medicaid. So this is a great opportunity and a good point in history for us to have this conversation. To start, I think it's important to look at a little bit of history and talk about what Medicaid's role has been, because the role of the federal government as a lever, whether it's by law, by regulation, is stark when you look at Medicaid's role in just bringing in millions of Americans who were historically outside of our healthcare system, either because they were poor, because they were communities of color, because they lived in neighborhoods with barriers to care. And it was actually the legislation combined with the Civil Rights Act that required that, along with funding, if you were going to receive federal funding, that you had to comply with federal rules. And so that was the beginning. I mean, that was 55 years. So we've had a 55-year history of Medicaid opening the doors. Having said that, I think laws don't enforce themselves, nor do regulations, and oversight becomes important. But let me just take a step back and talk about some of the rules I was involved in that I think have played a role in helping to improve equity. So one I want to talk about briefly is the access rule at the federal level, which was largely for fee-for-service. And then there was the managed care rule, which, you know, you could assume focused on managed care. And both of those had important elements that were designed to improve equity. Now, the challenge has been, both have been partially rescinded or fully rescinded, so they were part of the past. But when I say rules don't enforce themselves, that's an example. Not only do they not enforce themselves, we have changing administrations and changing areas of concern. So the oversight becomes important because even when the rules are in place, you've got to have the data and the information that can help us understand whether or not the rules that are being put in place are making a difference. But in addition to having the oversight, you have to have communities that are very much focused on caring about the implementation of those rules. So the toolbox has got to include not only the rules and the oversight, it's got to include how do you generate public will? You know, how do you get the focus within the agency, which is what I think Maureen was talking about, but then within the general public, so that that oversight is real and that it's also not considered a burden on the part of the state or the federal government. So I think, you know, the public will is where I want to end because, you know, I think that there are tools that we can use by rules, but with the creating an awareness that these problems are problems that deserve to be solved, that we ought to ensure that people have equal access or equity in access, is something that then means you will have the resources, whether it's fiscal or staff resources, to provide the oversight so that you can assure that you're not just putting in place rules that sit on the shelf somewhere, but that there are people in an agency, either at the federal or the state level, who care enough that they will enforce those rules. So I want to make sure, you know, we have a sense that there's a complement of tools that we have to use if we really want to bring about change.
That is so true, Marcia. You know, one of the things I think those of us who've been in the public light have recognized is that not only don't rules enforce themselves, is that rule enforcement has to be intentional and not broad.
Right.
And we have to, if we really expect policies to be implemented, then it has to be intentional. I think sometimes we think if it's a good policy or a good rule or good regulation, people will follow it. I think that's been part of the fallacy in our thinking. Just because something is good or has a good value doesn't mean without intention that it would automatically seep down into our into the mainstay and the mainstream of what we need. Toya, you've been you've served both Medicaid beneficiaries, both in managed care and in the fee-for-service system. Those are two significantly different systems as they have grown up, although I think the outcomes of both now are probably comparable. But what tools, incentives, and accountabilities do plans and providers mean to meaningfully focus on advancing equity and reducing inequality, particularly the racial and ethnic disparities? I mean, as you heard me say, we've known about disparities for a long time. COVID hit us in the face with how bad it really is. How do we respond now, both to the plans and to our providers, about our intent to make this change?
Yeah, I think there's a good reason for me why I left fee-for-service medicine a while ago and made my transition squarely and solidly into value-based and managed care, because I think that this fee-for-service infrastructure, the way it's been designed, doesn't have any levers or tools with which to meaningfully impact disparities, nor actually, honestly, I think to drive to outcomes in the way that we want to see. And so I think that there's a broad understanding, I think, recognition and acceptance of the notion that the status quo isn't, it's going to produce the outcomes that it was designed to produce. And if we've created systems that tie reimbursement to fee-for-service visits without a set of real requirements and obligations around the outcomes, around outreach and engagement and recognition that equity requires, in many instances, that we invest differentially to meet different people's and different groups' needs based on where they are. And so, I think, so leaving that aside, I think first and foremost, one of the core levers is value-based care and a push towards value, not just at the payer level, but increasingly at the provider level. Because if what we're trying to do is get alignment as close and as proximate as possible to the member, to the beneficiary, and holding accountable the person who holds the relationship for not only did this patient come in and get, an excellent standard of care, but if they didn't come in, did I go find them? And if I've done the same thing over and over again, should I get paid for doing it one more time if I haven't addressed the underlying need? Can I get paid for represcribing that insulin if I know that the person doesn't have food to take with it, or they don't have electricity to refrigerate it? Or should we be starting to say, as we are doing in value-based systems, let's actually tie these incentives together? And so that's one piece of it. I think the second is, and I think one of the things that's been so powerful about this moment, this sort of national reckoning in COVID, just unearthed and made impossible for us to ignore the thing that has always been true. COVID did not create racial ethnic disparities in health outcomes. It just shoved it right up in our faces in a way that we could not deny its existence. And now we can actually talk about it in a very different way. And if we can talk about it, we can measure it. And if we can measure it, we can hold people accountable to it. So starting to ask questions about how do you use policy levers like Medicaid to say, you know what, we've got to start collecting data about disparities. How do we measure this stuff? How do we talk about whether our program that we used to consider to be highly efficacious has disparate outcomes based on someone's race, or where they live, or their language that they speak, or their country of origin? And how do we make sure that we're looking not just at the median or the mean, but we're looking at the spread, and we're asking people to be accountable for addressing disparities in the outcomes that they produce? So I think that's another lever we have. We have policy, and it's always so, I'm so grateful for those of you who have held these really, really impactful and important jobs that create the foundation for those of us operating in the field, in the community, to get nudged and pushed. And I think my experience as, from the plan side as well as from the provider side is, if the regulators tell us to do this, we will do it. If it matters for them, it will happen. And really recognizing that, one of Medicaid's great blessings and also some of the challenges is that it allows so much flexibility at the state level, which means that there is so much potential. And we're seeing this over and over again as states rebid their RFPs. We're seeing them insert more clear language and guidance and recommendations and requirements that really, ideally, and those who take it up, really start to push us to measuring and addressing disparities in a very different way. And I can only imagine what's to come now that we've started to publicly have conversations about race and ethnicity specifically, in ways that I can only hope will start to show up in real, meaty and powerful policy recommendations that we're all then pushed to follow. So those are the things I think that are particularly exciting from my perspective.
And those are great. It is always good to hear when someone who's on the provider side recognizes that states do have flexibility and do have ways to create policy and enforce that policy. Maureen, alongside the focus on equity is a renewed recognition that individuals and communities served by Medicaid need a stronger voice in policy design. Probably if there's one major thing that I brought with me from Ohio to Pennsylvania is the importance of having that individual and community voice in policy design and implementation. And not only having their voice in it, but listening to that voice. How can Medicaid programs intentionally and explicitly ensure that their decisions are informed by the lived experience of its members?
Thank you, Estelle. So I want to do two things. First, when I think about COVID and one of the silver linings, I want to give you an example from our experience. So as our quality improvement component of our managed care rates was tied to HEDIS, as you know, given what happened with COVID, the HEDIS rates were not, as meaningful as they might otherwise be. So we completely revamped our approach using an IHI science of improvement method, developed 5 different projects that are specifically boots on the ground related to COVID, with smart aims targeted at individuals with particular areas of need because of COVID, children needing immunizations, restored citizens leaving prison, people in need of safer, more comfortable transportation in order to be able to get food because of COVID, and brought all of our plans together with every plan working on every team and a single managed care president running each of the teams. So they were combined teams from across the department and all of our plans working in concert as one on each of these projects, using smart aims, developing run charts, doing the metrics that's necessary. That was one of our silver linings coming out of COVID, was a realization, an experiential realization about the importance of working collectively across plans and at the state level with us as partners. Specifically then to your question about the individual voice, I want to give you a couple of specific examples. We must hire more individuals who have a lived experience. We're working on that right now with our substance use waiver, 1115 waiver, looking at increasing the ability of individuals with lived experience to work within our service system. Another example, we've developed some virtual trainings, simulations to use with medical students and with physician education across the state to give an experience of what it's like to be an individual in a wheelchair, a person with dementia, a person with an opiate use disorder, people who those physicians or medical students may not have ever experienced. An individual living in Appalachia who has a different view of the healthcare system than someone, say, living in an urban area. So we've been developing a series of those to help with education, CEUs, training. We have really worked very hard to increase the voice in our policy making. We heard from more than 1,100 individuals and organizations. We interviewed consumers within our Medicaid program in a facilitated dialogue in order to really try to extract from their comments the things we needed to do differently in order to make the program more attentive to their needs. The greatest in my view, the greatest compliment we got out of our planning experience was that people pointed to our RFP and said to me, I can see that you listened. I can see that you listened to the things I said we needed to do, or that my group that I associate with felt was needed, and I see it reflected in the requirements that you have put out to be considered by the plans. So listening and really trying to lean in to ways that individuals can be actively a part of our policy making and part of our systems and our system design.
Great, thank you. I know that when we talk about Medicaid, we often talk about individuals, but in reality, this is also very much about families. Marcia, you've done an awful lot of work focusing on improving maternal health, an area that really has been had significant disparities and tragically leads to poor outcomes and higher mortality rates for moms and babies. This is really about a family perspective as much as it is about an individual. Where do you see Medicaid opportunities to make a sustainable difference in long-standing disciplines? What needs to change in the current landscape to have us not only understand the role of individuals, but the important role of families and taking care of families as we look at changing the face of Medicaid?
So first, let me thank you for the question, and I want to acknowledge that the work I've done has been work in partnership with state agencies. You know, when I was at CMS, we pulled together an expert panel that was led by a Medicaid medical director from Ohio, a Medicaid medical director from Louisiana, and a whole set of other partners, including a few federal partners, HRSA's Maternal and Child Health Bureau, as well as CDC. So I think you're right. I have done a lot, but it's been in partnership with others that I think have helped us to make a difference. So to your question, what more can be done? First of all, I think it's really important for Medicaid to make the linkages in that broader landscape. You know, that for the health of the mother is not something that begins at pregnancy or at conception. That the health of the mother is very much defined and developed in the course of the neighborhood she and her family lives in terms of where she's working, in terms of where she's living, whether the housing. So all of those institutions that shape our lives are important. And what Medicaid has to do is work to develop those partnerships so that those other institutions that influence the health of the mother before conception and are so critical are focused on assuring the health of the family as you know, before the family is conceived. So I think that's the challenge, and the advantage of buying systems of care as we do through managed care is that managed care organizations have that flexibility. It's sometimes very hard when you're working with a single individual provider to make those connections. But managed care organizations can do that, and they have done that. And so it's trying to look through those organizational systems to help make the landscape include more than healthcare. At the Innovation Center at CMS, we developed what was called accountable communities for health. And those accountable communities were working to create those linkages across the different systems. So I think that's you know, the challenge and the opportunity for trying to not have you hear the phone, but I realize you couldn't hear me as well. So I think that's the challenge and the opportunity. So one more thing about working with families. So I talked about what happens before conception. So after conception, you know, I think it's important for us to, we've already talked a little bit about data, but a part of what we have to better understand is patient experience and the experience of the individual, but also of the family. That those experiences help shape people's willingness to um, enter the healthcare system affect their extent to which they are complying with the guidance that's being given by a provider. So we have to not only measure and monitor, but we have to make sure that the providers and the systems and the structures are set up so that families feel comfortable, families feel valued, families feel respected. Because otherwise, once you're in the healthcare system, you're not getting the kinds of outcomes you need or want because families are feeling not valued in the system. So our data and our systems can help us put in place the kinds of interventions and monitoring of those interventions so that we know that we're getting what we need. I want to close with one more thing that I don't usually talk a lot about, and that is the importance of research on this issue. For many of the problems we face in our healthcare system, we know a lot about the issues. For maternal mortality, it's an issue that we have only recently begun to focus on. And by recent, I mean the last 5 or 10 years. And this is an area where Medicaid can play a role because we have got to be a part of those efforts to learn, but then to make sure we're translating what we have learned about the challenges into best practices. And that's what often happens with research. There's this disconnect. You learn about a problem, but then you're not applying it and using it. And that's what I think Medicaid, there's this fear of Medicaid and it's a distrust of research in general, but Medicaid has not been as engaged in our systems to gather data, to learn from that data, and then to use that data. And that's what I think we've got to go forward with at a faster pace for this issue, because as you mentioned, 2/3 of births of women, of Black women are covered by Medicaid. And so trying to learn more and then put what we've learned into practice is what we need to happen with an urgency, given the magnitude of the problem.
Thank you so much for that, Marcia.
Marcia,
go ahead, Maureen.
Estelle, if I can jump in on Marcia's research point, we had a statute law passed in Ohio, Senate Bill 332, where we were required, now this is in a formalized way, but to do qualitative research and interview women of color about their experience with the system, and particularly those who were pregnant and their experience with delivery. And I can tell you that it was some of the most heart-wrenching, honest, and powerful feedback. We continue to do it in a series, but I just want to put in a plug for research that is as much about listening to the voice as it particularly where we may be more limited with quantitative methods, but listening to the experience and translating it into our practice.
Thank you for that, Maureen. And I also want to jump in. I just can't resist the importance. It appears that good research, getting good research into policy and to practice is taking longer and longer. It is not unusual for 5, 10 years to pass before we're getting the results of good research into operations. And we can do better than that. And certainly in this field, there's been an awful lot of good research. We now need to make sure that research can be moved to policy and policy can be moved to practice. And if we can do that, then we can use what we have. We don't need to reinvent. Just too difficult to pass up also. Toyin, let me pass on to you. We do know that the social determinants make a lot of difference in healthcare in all phases, and Medicaid is a good ground for that. What are some of the things that you see for non-medical supports that actually encourage the level of collaboration with other sectors?
Yeah, I not to sound a little bit like a sort of broken record, but I do believe this is where value-based care can be deeply helpful. So I'll give as an example the work that we do with the members that we serve now in 4 states, soon to be 5 or 6, that puts us as a provider of primary care, behavioral health, and what we describe as social care at risk for outcomes for a population of folks with very significant physical health and behavioral health and social needs. And automatically that economic structure incentivizes us to go figure out what the real barriers are for the populations that we're serving, and allows us to intervene and to invest in addressing those social drivers. And so that becomes a huge lever when you think about really tying providers in particular to value. It means that you're going to go excavate those locally and culturally rooted, often drivers that impact a specific community. You're going to be incentivized to go hire people from the communities that you serve, like we do, to build trust, so that your members that you're serving will be more likely to tell you the truth about what's going on for them, as opposed to the real mistrust and gulf that has typically existed between providers in the healthcare system and the communities we're serving. If we really need to understand what it's going to take to help keep this person safe and in their home, and that means we need to earn their trust so that we learn about the housing insecurity that they're struggling with, or the food insecurity that they're struggling with, or the income challenges that they're having, or the domestic violence that is occurring that's really the driver. You've got to really invest in understanding and overcoming those barriers. The second thing I think at a more sort of higher level from a policy perspective has been the states that we've seen that have called this out explicitly and really held managed care plans in particular to account for addressing social drivers. And I could pick a couple. There's several examples there. North Carolina certainly has gotten a lot of attention for the work that they've done in calling out the social drivers, in investing in a shared infrastructure for data collection, and for very clear linkages and referrals to community-based organizations to solve social needs. I know that Ohio is a state that we're soon to learn even more about, but has also really called out those social drivers, is pushing as many people into value-based care arrangements and into managed care as they can, and creating the right infrastructure for providers and payers to really invest in understanding what's going on for folks. And then we see a lot more creative examples for subpopulations with very significant needs in states that have managed to pull together braided funding. So as you think about, place-based care for people who are requiring residential treatment, starting to take advantage of how we can start to think about health more holistically than just health care, and think about what their housing impacts have on their health outcomes. And can we really think about that as an integrated bundle? Those are the sorts of initiatives and interventions that I think really start to move the needle and create a really receptive environment for the type of work that is necessary for these populations. And then I think ultimately, again, there's a lot of power in words and in how we name and describe what our mandate is. And so, again and again and again saying, even as a Medicaid payer, you are not just accountable for doling out units of healthcare. You're accountable for driving health, and we're going to measure that. And that's such a powerful foundational principle. But I think if you can take that lens, and we see states really do that, take that lens into everything, it starts to change the way that you think about investments, starts to change the way that the downstream providers and payers start to think about investments. And it allows us the freedom and flexibility to recognize that there are so many other levers for folks to really meaningfully move the needle.
That is so helpful to be able to understand the scope, that it isn't just healthcare, it's healthcare, it's people.
Mm-hmm.
And when we think about people, we know that we ourselves are complex, and we need food, we need shelter, we need healthcare, we need friends. And it's only when we can recognize all of those together, then we can make sure we have a healthy world. And again, I think, as you said, Tonya, all of this, COVID didn't bring our recognition of this, but it's slapping us in the face with the lack of it. Mm-hmm. So hopefully, as hard as 2020 was, maybe we have learned, and will make the future a little brighter, a little bit more optimistic. by putting what we've learned into practice. And I see that Allison is on the screen, which means we are about to start our question and answer session. Allison, I turn it over to you.
Okay, Estelle, thank you so much. And I think we could just hang on the line here and listen to this conversation all day, but do want to work in some of the great questions we've received from participants. So I'm going to make some assignments here as I go through, and I'll direct a question to one of you in particular, just again to try and run through a few of these in our remaining time. First question, Marcia, I'll direct to you. And here is the question. I am interested in the development of the public will, but also the will of administration's will across gubernatorial administrations at the state level. So there is not schizophrenic reaction as new administrations come and go. What are your recommendations to build a consistent, deliberate, and sustained move toward health equity? And who should monitor and enforce accountability and reporting?
Because, you know, as we know, governors are governors and they operate in their own states. Certainly, let me start at the federal level, because at the federal level, you know, as I mentioned, CMS, or at least Medicaid and CHIP, started to work with HRSA and CDC, two entities that had similar missions, at least on the issue of maternal and child health, but had never worked together. And so, you know, you've got to start with building consensus among and public will, you know, at the federal level, and then move, I think, or at least, you know, use those levers that they have, because they drive dollars. They drive dollars. Tonya mentioned the fact that when regulators speak, the purchasers tend to listen, or at least those who are, you know, you're purchasing from. And so, you know, while I think some of the public will certainly can come through efforts that are, you know, public messaging, some of it also has to come from incentives from the federal level where dollars, you know, are available. And so you put those two together, you put the top and the bottom, you know, but so then I think, you know, you've got to pull together the grassroots movements, you know, because I don't think you're going to get the public will just from either the federal or the state level. So trying to get this on the radar screen of the governors and the public health agencies, and then with the grassroots is what I think we will have to do. And in terms of who's accountable, you know, it's there's so many groups that have formed. You know, the National Collaborative on Health Equity, to give you an example of one. There are entities that have, you know, reaches across the states, and there are entities within states. The Center for Healthcare Strategies, for example, has multiple entities that they are interfacing with. So you know, our foundation partners can be a part of this effort. So there is no one solution, and I wish I had, you know, thought through more of the how and the mechanics of it. I just know it needs to happen, and I've not thought through the details. But I'm glad that there is interest in doing that, because I definitely think that is where we need to go next.
Great. We're all in this together for sure.
Yeah.
Thanks, Marcia. Okay, next question. This is specifically related to long-term services and supports. And so, Maureen, I'm going to direct this question to you. States vary so much in their commitment to home and community-based services. Can you comment on the racial equity implications of the patterns of these differences? A related question is the observation about higher rates of COVID deaths in nursing homes with large numbers of residents who are racial and ethnic minorities. How does this fit into these home and community-based services differences across states?
Yeah, that's a great question, and there's a lot there. You know, I want to tie back to something that I think Marcia said at the very beginning. You know, remember that we have a federal policy of rebalancing our long-term services and support system to put more emphasis on home and community-based services, self-direction, use of family members, I mean, all those tools. And states are moving in that direction. at different speeds. So, you know, I keep pointing to that policy as kind of a North Star that we need to continue to pay attention to. I would also say that, you know, I've spent quite a bit of time during COVID interacting with our nursing home colleagues, and I do believe that COVID will have a long-lasting, very significant impact on that industry. I can't even fully imagine it right at this moment, but what we see in our state is the continuing voting of people with their feet, and certainly the experience of the high numbers of individuals who have died increasingly or even exponentially because they are individuals of racial and ethnic minorities is really calling out the issue of what is it that people want as they age, and we've just got to do more and lean more into honoring the home and community-based service needs and demands of people that we work with. I think there's going to be a serious ongoing conversation about this in our public dialogue, and it just has such extreme importance about our country and the society that we want to be judged as.
Thank you for that, Maureen. There are a ton of questions. Oh, please, Estelle, go ahead.
Let me jump real quickly in on this one. It seems to me that as we get into long-term living, one of the things we know is that it's split between Medicaid and Medicare. And while they exist within the same entity, HHS, CMS, they really operate rather separately. And it may be time that as we look at long-term living and people's choice, you know, I'm well closer to 80 than to 70, that in choosing the future, if I want to age in place, I need my Medicare and and the potential of Medicaid to come together. Perhaps the role for our federal government coming up is trying to figure out how do we meet these long-term choices by doing more integration as opposed to pulling apart. Because I think states will continue to struggle as long as we keep Medicaid and Medicare in such different pockets. So, and I believe that as we work towards health disparities, that's going to be one of the issues that comes up. I, as a fairly educated health person, still have trouble sometimes sorting the buckets. So hopefully as we become more sophisticated and learning from our COVID lessons, looking at Medicaid and Medicare as linked would help.
Well, and if I can jump in here, Estelle, because you didn't introduce yourself at the beginning as having been from Cleveland, where we met. Yes. I do need to point out that Ohio is the largest of the CMMI Medicare, Medicaid dual projects. So you can come on back to Ohio
and age in place.
So, but we still have a lot to learn from the work that we have been doing in that area.
That's great. Thanks, Maureen, and thank you, Estelle, for jumping in there. Toyin, I'm going to address this one to you. Here's the question. I may do some paraphrasing here because it's long. So here goes. We on the call all agree with the important principles of equity, access, and quality of care that you are describing, but Medicaid is only one piece of the system. How can the Medicaid experience best help drive the rest of the system, often privately run, to actually change in the directions we are discussing? Wouldn't the chance for true systemic change be way greater if all parties share the same values and goals? So Toyin, I'll hand that to you.
It's a big one. I mean, I think, you know, we're talking about Medicaid and the incredible leverage it has in driving equity because of the size of the population that's covered that receives Medicaid benefits, the impact on parents and children in particular, and the real opportunity for long-term impacts downstream of those early and very, very informative and very kind of crucial years in people's lives. The impact it has in caring for folks in providing coverage for people with disabilities, and for people, approaching their later years who have more complex needs, as well as the fact that we know that racial and ethnic minorities are overrepresented, disproportionately so, in Medicaid. And so, I think that I understand, and I think there's an important kind of looking across the sector, and there's an important signal that we can have through success in Medicaid and through lessons in Medicaid. But this is a deeply powerful program in and of itself to impact a large swath of the population that have significant needs that could be deeply impacted by the types of policies and innovations and interventions that the Medicaid programs deliver. And so, I think the piece that Marcia raised earlier about research and about creating some structures for longitudinal dissemination of best practices and outcomes is really powerful here. Medicaid, because of the way it reimburses providers, is never going to be sort of a market shifter, not in the same way that Medicare is. But certainly, we see that, we see providers tend to be quite bifurcated. Providers who take Medicaid often only take care of those types of populations. So there's less opportunity, I think, for cross-pollination in the same way that Medicare can really drive a market or drive a sort of provider behavior. But I think that there's something here about saying, if we can learn what it looks like to drive better outcomes for populations with heterogeneous needs that include social needs, that include folks who've experienced significant disparities in health outcomes, let us disseminate that. Let's create policy and process around those best practices, and let us, at least at a minimum, create more opportunities to scale those learnings. I think you'll also see folks like us, who are provider systems, provider groups that have distinctly chosen to work in Medicaid with a recognition that that sort of best practices, clinical models, interventions built for the top 1% of a commercially insured population will never trickle down to those who really are struggling. And so there's a lot of I put a lot of stock in the notion that you build for that population you're seeking to serve, and things will flow up because they always do, but they're never going to trickle down. And so I really would urge us to think about how do we have maximal impact for folks who are covered by Medicaid, who are eligible for Medicaid. How do we expand that footprint? How do we get the rest of our states that haven't yet chosen to expand Medicaid to do so? Let's figure out what works here. Let's disseminate it and demonstrate it, and the rest will follow. But certainly it doesn't come the other way around.
Thank you, Toyin.
Okay.
Okay, I'm going to try and get one, possibly two more questions in here. So Marcia, this one's coming to you. And the question is, you've talked about research and quality measures. What do we need to know that we don't already know to create solutions?
That's a good question. Because actually, when I shifted my work from largely writing and analysis, it was because I had this sense that the challenge we faced was not what we didn't know, but implementing what we do know. But now that I'm doing additional work, both at the state level and the community level, I would say there's still the gap between the time it takes to improve knowledge and transform practice is so long. Estelle talked about that earlier. So there is still new knowledge. And, like I mentioned on maternal mortality. I mean, I think there's a lot more we do need to know. But I think it's the translation. It's like, how do you get systems to listen about what we know about what can make a difference? How do you get clinicians to listen? How do you get state agencies to listen? I mean, it's we talked about listening to consumers, and I think that's important, but also these systems that kind of run on automatic pilot have a hard time taking a step back and paying attention to new knowledge. So we definitely need more research on how do you, scale up? How do you get what is known into the field? And then, I I think the specific question really was, what do we still need to know more about? And I think, you know, much of the research still on equity is still about on defining the problem. It's not on understanding what solutions make a difference. You know, so if I could flip a switch and redesign how we allocate and invest in research, I would better balance as a start how much we spend on learning about the problem with how much we invest in learning about solutions. So that would be, I think we need to learn a lot more about, you know, what makes a difference. I'll stop there.
Thank you so much for that. Maureen, I'm going to send the final question your way in our waning minutes here, and that is on the eve of Inauguration Day tomorrow. Are there new levers to be employed by the new administration that could do the most to affect equity? What would you ask of your new federal partners as we head into January 20th here?
Well, thanks. So I guess I have a little bit of COVID on the brain, but there is a lot of innovation that has come out with COVID, and there have been a lot of new flexibilities and tools given to states. And all of us right now are looking at those with an eye toward which of those flexibilities should we keep, which of those were useful for the time, but maybe not for the long term. And so some of those, again, even just within a COVID context, there still is some needed change at the federal level to continue some of the telehealth changes to accommodate both synchronous and asynchronous communication. There is a great need for us to focus on the workforce shortages that we have. And in that regard, I mean, my sort of mantra is whatever we can do to expand the workforce, self-directed care, families as caregivers, I mean, anything to enable people to practice at the top of their scope, as well as to expand the workforce, peers, family, self-directed. Those are ways that the feds can be real partners with us. And there just, again, are a lot of learnings and innovations that states have come up with through COVID that we need to take advantage of.
Well, thank you for connecting it back to timely issues, Maureen. And I want to take the remaining minute that we have to extend my sincere appreciation to this unbelievable panel and to our fabulous moderator in the form of Estelle Richmond, our board chair. You all have done a world of good and by being so generous with your insights and your time today to share with all of us your thoughts on this really important topic before us. I want to also just acknowledge while the impetus for this has been CHCS's 25th anniversary, all of the work that we do at CHCS is in partnership with so many of you out there who have joined on the call today, so many of you working so hard and in such committed fashion to address inequities and to improve health where it's needed the most. And so thank you for your continued partnership as we continue on this journey ahead. If you have time, please stay on and complete the evaluation. We would really appreciate your thoughts. I want to thank the CHCS team who has worked together to pull this event together and remind you all that a recording is available and you should receive that via email for all of you who registered within the next day or so. So thank you again. Thank you, panelists. And here's to continued optimism. As Toyin started us out with, we are all absorbing and embracing that optimism and look forward to a more set of promising days ahead. So thank you all and have a great rest of your day.
Thank you, Allison. Thank you very much.